Dr. Edlow, welcome to the Focus Matters podcast. So excited to have you here today. This is,
Thank you, Noah. It's an honor to be here. Really excited for our discussion.
this is something we've been working on for months, but this is it. We've arrived. So let's jump right in. I've known you now, I think, coming up on 2 years. I have a deep sense of your work, tremendous respect for what you do. But our audience probably doesn't know you, so I will do my best to introduce you, and then you can fill in the gaps. So Dr. Brian Edlow, based out of Massachusetts, is the Vice Chair of Research at the Department of Neurology at Mass General Brigham. He's also the Director of Laboratory for Neuroimaging of Coma and Consciousness at MGH. I just want to know how that even fits on your business card. And a clinical neurologist at the Spaulding Rehabilitation Hospital. How is that for scope?
Thank you. That covers it.
So Brian comes to the show where we normally talk about focus and attention and brain health from a really unique perspective, because you have a deeply clinical background. As everyone will learn as we go into this episode, you look at consciousness at its very, very root level, which I'm very excited to discuss, because you obviously can't have focus. And even the concept of mastering your attention is meaningless without consciousness. So we're really going to go to the root of what makes the brain so special and what is the mystery of consciousness and such. And then we'll also talk about some of the other work you do that really looks at brain health and soldiers and the inspirational work that you're involved in and really leading to help identify ways of protecting our soldiers over time so that they can not only serve the country, but when they're done, serve their families and have rich and meaningful lives. So tremendous scope of work. We'll see if we can condense this down into a reasonable period of time. I always joke these podcasts are now becoming these long format podcasts, like 3 hours. I don't do that. We try to keep it to about an hour, and we'll get everything in that we can. So again, welcome. Great to have you here.
Thank you, Noah.
So I'd love to jump right in and start with your core work, your work regarding consciousness and coma. And as I mentioned briefly before the show, did a little research and found your quote unquote origin story. So I want to start with the origin story. As I have heard early in your career, I guess during your residency, you're doing rounds, you're studying coma and consciousness, and you touch or you reach out your hand to a patient who is by all general measures not conscious, and you get a conscious reaction and you get a response. And this is this moment that changes your life. So A, is that true? And if it is, take us there.
It is absolutely true. It was a formative moment in my personal and professional development, and I appreciate the opportunity to share that story and to reflect on it. Was a fourth-year medical student at the time, so this was before residency, on a neurocritical care rotation at University of Pennsylvania, where I was training for med school, and taking care of a young man who was a cyclist for his college team, hit by a car, hit and run, comatose. And the context, and for your listeners who might not be familiar with how clinical care often works in the intensive care unit, we are providing the best treatment we can for each individual to help them have the best possible recovery. And we often face, a fork in the road life or death decision within the first 7 to 10 days of an individual's arrival to the ICU. Do we continue with aggressive life-sustaining care, which typically involves placement of a tracheostomy tube and a feeding tube? Or if even the best possible scenario for a long-term recovery is not a quality of life that would be acceptable to that individual, then do we transition to comfort-focused care and allow that individual to pass away peacefully in the ICU? That is a conversation that we have with families every day in the ICU. It is a profoundly important decision, and our guiding principle is respecting the dignity and the autonomy of that individual. What would they want? And we look to their family, their loved ones, to help us understand what is the most appropriate care to provide to that individual. For a young patient, often the goal is to continue with aggressive life-sustaining therapy, give them the best chance to recover. But sometimes things look bleak. And for this particular patient, this young man, there were some signs on the MRI scan that pointed to a low likelihood of long-term recovery. And so the message that the medical team communicated to his parents was that he may die in the ICU despite our best efforts to treat him and to save his life. And even if he survives, he may end up in a vegetative or a minimally conscious state. Despite that poor prognosis, his parents said, we're going to keep going. We're going to give him a chance. We're going to see how things go. He undergoes the tracheostomy and the feeding tube that I talked about earlier. He's comatose for 14 days in our ICU every
14
morning.
days.
14
14
days
days.
every morning on rounds. As the medical student, you get there for pre rounds and you're, examining him, squeeze my hand, trying to open his eyes, trying to interact in any way behaviorally at the bedside that somebody can express themselves when they're connected to lots of machines, lines, tubes, and drains. And on day 14, after having gone through this ritual, multiple times a day for the past 2 weeks, unexpectedly, he squeezes my hand.
Wow.
And the chills experienced in that moment are indescribable. Have had the opportunity to be present at moments like that dozens of times since then. It is equally inspiring every time
Mm.
to be there at that
Mm.
moment of transition from coma to consciousness. Um, and sorry, I'll pause there. I'll let you jump in.
No, it's a powerful story. So you say from a couple pieces there. I want to back up to. I think because there's so much density to the story you just told. So my experience in the ICU is not as a professional; it's as a patient. Not myself, but generally family members. I've been there once for something minor. But as you know, my dad went through dementia and Alzheimer's, and he was in and out of critical care several times. And as a family member, when you have to start considering those options, it's obviously tremendously stressful. And you mentioned something about trying to make a decision on what is not only best for the family but is what is best for the patient, and understanding that patient's sense of agency when there is no consciousness is such a dilemma, because it's not like you can have a conversation with them. So how do you go about differentiating what the family wants, which can sometimes be incredibly emotionally biased because of the stage of grief they're in, from what you think could potentially be best for the patient?
Incredibly important and insightful questions that you're asking. And it speaks to the interface between the clinical considerations, the ethical considerations,
Mm.
some interpersonal dynamics. We try to support family members who are going through, in many cases, the most difficult experience of their lives. They are in shock. They're sleep deprived. They are stressed beyond belief. And so we're sharing information that is quite complicated. Even
Mm.
for us as clinicians,
Mm.
sometimes we struggle to wrap our minds around all of the complexities of the prognostic data that we're sharing with families. So from the standpoint of communication and just supporting another human being through a really difficult time in their life, this is as challenging as it gets. We meet multiple times to ensure that the messages are heard clearly, because it's so hard to process it each time. We try to be as compassionate and clear in our communication as possible, but it is difficult. To your point about understanding what that individual would want and respecting their autonomy, their dignity when they can't talk to you, that is a fundamental challenge. We look to the family to tell us whether the patient has ever verbally shared what they would want in that situation. Maybe they have written advanced directives,
Mm-hmm.
but those advanced directives don't always cover the nuances of a particular
Sure.
situation. So
Sure.
even when somebody has written down or expressed verbally their wishes, it doesn't always fit the particular
The
circumstances.
circumstance. Yeah, I could see that.
We do our best, but I'll share a statistic with you, which is that if you look at traumatic brain injury, which has been my focus both clinically and from a research perspective, really since that moment in medical school, the vast majority of individuals with a severe traumatic brain injury who die in the intensive care unit die because of the withdrawal of life-sustaining therapy. Not because
Oh,
their
interesting.
injuries were untreatable, not
Interesting.
because we could not save their lives. They die because a decision is made to allow them to pass away peacefully in the intensive care unit. And for some people, that may be appropriate.
Mm.
There are people where the family says, based on, even if we acknowledge with humility, and I always start and end every one of these discussions with an acknowledgement that predicting outcomes in the ICU is an uncertain art and science. We acknowledge that there's always some uncertainty, there's always a range of outcomes, but there are families who tell us even the best case scenario is a quality of life that my son, daughter,
Mhm.
husband, wife would
Mhm.
never
Wouldn't
accept.
accept. Mm.
And in those cases, perhaps it is appropriate to
Mhm.
transition to comfort focused care.
Mhm.
Or a family member will say, the best case scenario would be acceptable, but going through months of
Mhm.
dependence, 24/7,
Mhm.
feeding, toileting, groom,
Mhm.
everything, they would never accept
They
that.
would never
So
accept it.
in those situations, ethically, clinically, it's appropriate. But there are people where we get it wrong. And
Mm.
70 to 80% of patients will die because of the withdrawal of life sustaining therapy. We'll never know what would have happened to them, but
If you'd kept
statistical
them under
modeling
care.
studies
Mm.
suggest that about a third of them would have been independent, functioning independently by 1 year.
Mm.
These are statistical modeling studies. They're not
Right.
perfect, but
Right.
it gives you a sense that there are some people who probably could have had a meaningful neurologic recovery if they had been given the chance to do so.
That's powerful. That's not a light dinner topic. You said you sometimes get it wrong, but that was interesting because I don't. If you're making a decision based on the input from the family, then who's getting it wrong? And is that really? It's got to be so challenging to live with wrong or right in this circumstance.
So, so it's a great question. We only really know if we got it wrong if the patient is given a chance to determine
Mm.
what their long-term recovery might be. And I cannot tell you how many times, and this is something that I focus on. This has been my career. I've read every paper, have been involved in many studies in this field, and I still will frequently get it wrong with respect to predicting long-term recovery.
Mhm.
And if we tell a family that we expect their loved one to have a certain set of deficits, cognitive deficits,
Mhm.
behavioral, physical, whatever it might be,
Mhm.
based on the pattern of injury on their brain scans, we make these predictions. We do the best we possibly can. And to go back to the patient from medical school, I told you what our prediction was, our prognosis. 5 years later, he rides coast to coast from Cali back to Philly
Of course he
on
does.
his bike, stopping in every state along the way at rehabilitation facilities to raise awareness for TBI recovery.
Fantastic.
It doesn't get more humbling and inspiring than that.
So what does that say? Let's pause there for a moment because it's actually not that unique a story. And my background being in human performance, and for a while I was running a coaching, testing, training center for triathletes. Road injuries are not uncommon in cycling, unfortunately. Even the best helmets don't necessarily preserve you from true TBI. And these are people who are deeply competitive. They take their health very seriously. And you hear these stories of people who are giving these very, very glim or dim prognoses. And 2 years later, they appear to be back fully functioning. What are we, what's the mystery here? What are we learning about the brain and neuroplasticity and its ability to remap and rewire? And where is the magic? Is it regenerative, or is it more the brain is saying, okay, this part of the brain isn't working. We're going to move these processes to a different part of the brain. And we're just so good, or the brain is so good at that rewiring that it brings this vitality back to somebody's lifestyle.
There are a couple of different considerations here. One is, and you alluded to this point, that there are many stories like this in the popular press, or whether it's friends or family members that we have who have had this type of experience of an unexpected recovery. And I'll start by saying what was considered a miraculous recovery, like the story I just told,
Mm-hmm.
maybe a decade or two ago,
Mm-hmm.
is now relatively common, particularly in young patients with traumatic brain injury.
Hmm.
And I want to make that distinction about
Yeah.
age because, as you've
Right.
talked about previously on this podcast, younger brains have a greater capacity for the plasticity mechanism that you mentioned a moment ago, greater capacity to rewire and heal and regain the function for what's been lost. Several of your prior guests have talked about plasticity, and I would refer back to those episodes. Dr. Tommy Wood did a great job of discussing this. The only other analogy that I like to use when talking with families is you think of a highway being blocked. There's construction on the highway. In this case, we're talking about the axonal pathways, the white matter pathways that send electrical signals from one part of the brain to another. They can get disconnected. So at the moment of impact, as the head rotates quickly back and forth, those rotational forces can stretch or even tear an axonal pathway, leading to a disconnection like a blockage in the highway. But just like when you're driving, you take a detour, your brain can build those detours. It can create new connections, not by growing new brain cells, although there's
Right.
some evidence that,
Not neurogenesis, but
right,
remapping of existing neurons.
exactly.
Yeah.
And, there's an emerging field on neurogenesis in the hippocampus and in the olfactory bulb. That's a kind of a separate issue, which is really not the main mechanism of recovery we're talking about here. We're talking about the pathways that are uninjured creating new connections to bypass the blockage. So creating detours within the brain to reroute the signals and rewire those networks. That process of plasticity is more robust in young brains, and it is particularly evident in traumatic brain injury as compared to, for example, a hypoxic ischemic injury to the brain, somebody who has a cardiac arrest, their heart stops beating, decreased blood flow, decreased oxygen to the brain. In that setting, plasticity can still occur, healing is still possible, but the recoveries tend to be less common and less substantial than they are in individuals with traumatic brain injury.
And is that's interesting. Is that why do we think that's true? Is that because of the difference mechanistically that we're talking about? Because so backing up for a moment, the old school assumption around concussion. Correct me if I'm wrong, but as a martial artist and I boxed for a long time, and everybody's like, "Doesn't it hurt when you get hit in the face a lot?" And those in the boxing community, our answer is always, "What? Huh?" Um, but the idea was that there was a misconception that the brain's actually sort of bashing up against the skull and that that's what's really causing the damage. But it's not true, right? It's the acceleration and the deceleration within the cerebral spinal fluid. So even though the brain isn't making actual contact, it's the acceleration and deceleration that's causing these injuries. Is that generally true?
Yes, well said. And that mechanism of acceleration, deceleration, stretching, or tearing those pathways that send the electrical signals, that is the most important type of injury as far as being implicated in causing coma. So
Mm.
you can certainly, if somebody has a car accident, their head moves quickly back and forth, and they hit the windshield, you can get injured, a localized bruise or contusion
Okay,
from the
almost a
blunt
hematoma.
impact.
Yeah, sure.
Exactly.
Yeah.
And that hematoma or contusion can swell and it can
Hmm.
cause problems as well.
Hmm.
But if you look at people who are comatose from the moment of their injury, those are typically people where the primary mechanism is the rotation back and forth, as you said. In concussion, it's the same mechanism, it's just less severe, and the
Mm.
period of unconsciousness may be very brief, or somebody may never lose consciousness. They might just have stretching or tearing in parts of the brain that are not responsible for consciousness.
Mm. So interesting. So it's hard not to default to personal references in these kind of stories, and I think back to my numerous concussions as a young person. The first, I was on the monkey bars. Remember monkey bars? I don't even know if they allow them anymore. Um, the other kid had their legs wrapped around me because the goal was to pull the other person off the monkey bar. They worked. I fell backwards, hit my head on what was supposed to be sand, but there was about a quarter inch of sand. Lost consciousness. These are the good old days. Nurse came, got up. I walked home from school. So there are a couple examples of that. But again, so young. And at that point, I think at that point, I may have even been, still preening neurons. Like you had this abundance of neurons. But part of the takeaway here is this whole concept of neuroplasticity, while it extends through life, there are periods where it's much more available. Now, we're looking at it from a therapeutic standpoint, but to flip it to just in terms of wellness and optimization, it seems to me that this shines the light on take advantage. If you're a parent or if you're in your 20s or teens and you're listening to this, there's this golden age of neuroplasticity. Take advantage of it. Really stretch your brain. Like apply these concepts of creating more headroom that Dr. Wood talks about, because it's so much easier to do when you're younger. Is that fair?
Well said. Agree 100%. And I'll just quickly, there was one part of your question that I didn't address yet pertaining to mechanisms of recovery from
Mm,
TBI, why
yes.
people
Right.
tend to do better as compared to cardiac arrest. And there are two things I'll mention here, and this will start to become relevant when we get into the blast traumatic part of the conversation. One is if you go, and many family members, when they hear that their loved one on an MRI scan has evidence of what is often referred to as diffuse axonal injury, a term that describes that rotational force we just were discussing earlier. That rotational force can stretch and tear these axons throughout the brain. And so diffuse axonal injury refers to widespread injury
Widespread.
to
Yeah.
the electrical pathways, the axons.
Right.
The term diffuse, though, suggests that it's everywhere.
Mm,
But the reality is, if you look under a microscope when somebody passes away and you look at the distribution of injury, it's not every axon, it's not every one of those pathways that's sending the electrical signals. It is in multiple places, but not
discrete.
everywhere. Exactly.
Thereby enabling to go back to your metaphor, thereby enabling the bypass around the blockage.
Exactly.
I can see
So
where this is going, but now when we get to cardiac arrest,
it's more, it true, not always, but it can be more
mm,
diffuse, it can be more global. And
mm,
the other important distinction is with cardiac arrest, cells that are deprived of oxygen and blood typically die after a
right,
certain amount of time. That
right,
time can vary from person to person. Whereas with trauma, these pathways can be stretched but not torn.
mm,
And when they're stretched, they can be dysfunctional, but they can still heal. So another
interesting.
mechanism of recovery is not just building a bypass, but actually fixing the damage to the highway.
Now, is that through myelination, sort of remyelination, or
It can be remyelination. It can be fixing there's a protein cytoskeleton inside those axons. It's
Mhm,
like a scaffolding that
mhm.
gets disrupted. But as long as that pathway is not completely cut in half, it can potentially heal and recover. And so you might have two patients in adjacent rooms, both in a coma after a traumatic brain injury. They look the same at the bedside. One has complete disconnections of those pathways. The
Mhm,
other has stretched pathways that are reversibly injured and that can
mhm.
heal over time. And we don't have a theme that we'll come back to with Blast TBI. We don't have good enough tests yet to distinguish those two patients.
That's what I was about to ask. So, how do we know? How do you diagnose the level of trauma, and how do you differentiate between those two different types of injuries? Is that something you can do in fMRI at this point or not?
So I'm smiling as you ask that question because it speaks to what has been kind of the focus from a disorders of consciousness standpoint of my research career for the last 20 years or so, which is trying to detect signs of brain function and covert consciousness, which I'll define in a moment,
Okay.
in individuals who cannot physically express themselves at the bedside. So one issue that we haven't gone into yet is that there's some people who have disruption of the motor pathways.
Mhm,
So imagine that the highways sending the electrical signals
mhm,
to the arms, the legs, all the muscles that allow you to move and to express yourself have been disrupted. Or imagine somebody was in a car accident and they had trauma not just to their brain, but to other parts of their body. Maybe they're immobilized. Maybe they're in so much pain that even if they could move, they just don't want to when we ask them
mm,
to show a thumbs up or wiggle their toes. Maybe there's been stretch injury to the peripheral nerves. There's a
mm.
long list of reasons that somebody with a trauma might not be able to physically express themselves, even if they are conscious. And so, just about the same time as that formative story I told in the beginning about the patient in med school who squeezed my hand, around the same time in 2006, a group in the UK led by Adrian Owen comes out with a paper in Science. So, not every day that a case report is published in Science, where a young woman who was a couple months after a traumatic brain injury was believed to be in a vegetative state, meaning she could open her eyes,
Mhm,
signs of wakefulness, but
mhm.
no signs that she was
No
aware,
responsiveness.
no
Yeah.
responsiveness.
Okay.
Nothing on her exam suggesting she was aware of herself or the environment.
Mhm,
They put her in a scanner, they do functional MRI, they ask her to perform different tasks. Imagine walking around the rooms of your house. Imagine playing tennis. And her brain lights up.
lights
It
out.
responds just like yours or mine would. And in an anatomically specific manner that was different for those two imagined tasks. That study,
I literally got chills right then.
it's so that study created this idea of covert consciousness. Consciousness
Overt.
that
consciousness. Okay.
cannot be detected on the bedside behavioral exam,
Mm, mm,
and that can only be detected with an advanced neurotechnology like task-based functional MRI, or you
mhm,
can do the same thing with EEG. You put electrodes on the scalp and
mhm,
you ask somebody to imagine doing a task,
mhm,
and we can see with fMRI or with EEG volitional brain activity,
mm,
purposeful brain activity,
mm.
even when somebody can't physically express themselves.
Amazing. Yeah, I immediately I like to read a fair amount of history, and these days often it's like Civil War or Revolutionary War, etc. You could think about how many soldiers passed who could not respond in much less developed science, but could not respond. But almost if they were just stabilized and left alone, probably could have returned to some normalcy in life. Yeah, interesting.
It's incredibly humbling, and 2026 there have been so many advances, and we're all talking about AI and brain computer interface. I mean, there's so much exciting, groundbreaking science that is improving human health, improving the quality of the care that we provide, but there's still fundamental gaps in our knowledge about which of these pathways are most important for consciousness. There's still gaps in our ability to detect consciousness for patients we care for. And these are profoundly important uh, limitations to medical care, because if you talk to families, and we work with a neuroethicist named Michael Young, who has led several studies talking to family members about what is most important to them when they think about the next steps in their loved one's care. That
Yeah,
fork in the road decision. Do we
right.
continue life sustaining therapy or not? The emergence of consciousness in the ICU is consistently one of the biggest or the biggest factor in whether a family member says, yes, let's keep going.
But what is consciousness?
Uh,
Maybe
that's
not to stop the bus, but we're using this term as if we put 100 people in the room, we would all agree. And to a family member who has no medical training, consciousness may come back to overt consciousness. It's no, I need to see that this person is with me. I need to see that they're connected. Does does the covert consciousness threshold really resonate in those deeply? Because I can see how it does clinically. Does it translate personally all the time, or is that sometimes too ephemeral for people to be able to understand?
it's a great question. And my short answer is it depends specifically on the context. Is it a
Mm,
chronic? Is it a patient in the chronic stages of brain injury or acute? So I'll start with the chronic. If somebody is months or years out from their brain injury, and we perform one of these assessments, it's often done from an investigational perspective, but now these tests are endorsed by clinical guidelines in the US and Europe. So at Mass General Brigham, we're offering these tests for clinical care as well as part of our emerging consciousness program. And if we detect covert consciousness with fMRI or EEG
hmm
in a patient in the chronic setting, usually these are patients in long-term care facilities. Sometimes their family members have taken them home to care for them at home. Maybe it suggests that there's a slightly higher chance of some functional recovery, some ability to physically express themselves down the line, but the gains that are predicted are pretty limited, and that is not often welcome news for family members.
mm,
Sometimes the and having had this conversation with many family members over the years, it is a heartbreaking experience to see the range of emotions from, on one level, wow, my loved one is there. Maybe they can hear me, that there's some sense that there's a connection
there's
there.
still connection. Yeah.
And then within, 30 seconds or a minute, you'll see the family member's frame of reference change to, wait a minute, this is terrible. You're telling me they're in there and they're
Mm,
aware of what's
the
going
trap.
on. I
Yeah.
mean, can you imagine the loneliness, the despondency, it's hard to imagine. So it is not always welcome news in the chronic setting.
Mm,
In the acute setting, the big distinction is that there's a group at Columbia who has shown that the presence of covert consciousness in the ICU, just like overt behavioral signs of consciousness,
hmm
it predicts long-term recovery.
Okay.
So early on, and I should acknowledge here that these are studies with a couple dozen patients. The largest one was 110 or so patients. These are emerging
Right.
findings,
Right.
but there's growing evidence that early emergence of consciousness in the ICU as detected by these tests predicts long-term recovery. And for that reason, family members are often very excited to
Very
hear that
excited.
their loved,
Sure.
even if
Sure.
it's not a state that they would want their loved one to remain in.
But it's a sign of hope that there's a
Exactly.
future. Yeah. That's
Exactly.
amazing. And I'd have to imagine when we look at those two technologies, the EEG and the fMRI, the beauty of EEG, even though it doesn't have the same level of sensitivity, you and I have talked about that, but it scales so well, right? You could literally have it in every ICU in the country versus availability of fMRI is still fairly limited, correct?
Exactly. It's safer, it's cheaper, more readily accessible. And just to highlight the safety issue for a moment, we've been doing these research studies and clinical assessments on patients in the ICU since 2012. I'm very happy to say, I'm knocking on wood and crossing my fingers as I say this, that we've never had an adverse event transporting a patient to the scanner or in the
Mm,
scanner. But
mm.
these are high stakes tests, and all credit to the incredible neuro ICU nurses who care for these patients, who keep them safe, the MRI technologists. But just transporting a patient who is critically ill from an ICU um, bed to the MRI scanner table is a high risk
Has risks. Yeah.
endeavor. These patients are connected to lines, tubes, drains, where any of them, if they were to become disconnected, could cause a serious adverse event. So it is, but we do these tests because they have profound implications for these prognostic discussions with families.
Amazing. Okay. So let's shift the conversation a little bit because we could do this for a long time, but it's so impressive. It really inspires a lot of reflection on the question around consciousness, quality of life. I'm curious to know a little bit about you and your journey in this because you're a busy person, you're a family man, right? You have kids. So let's talk about Brian and Brian. How does Brian maintain focus? How does Brian maintain brain health in the midst of this very potentially chaotic, but certainly high stress environment? Because I think that may be an interesting transition as we talk about ReBlast.
With great difficulty. And I'm smiling as you ask that question because I'm reflecting on some of the guests that you've had. Bain, whose episode was incredibly compelling. Dr. Wood, as we mentioned earlier, talking about all the things that individuals can do, civilians and military personnel or athletes. And you've spoken eloquently about this to maintain peak performance, nutrition, exercise, sleep. And as I'm listening to these episodes, I'm thinking to myself, wow, I got a lot of work to do this because I do not excel in any of these areas. But all joking aside, I would point to mission and inspiration. The story with the patient in med school, that was the singular focus for my clinical work and research. I founded the lab for neuroimaging of coma and consciousness when I joined the neurocritical care faculty at Mass General Brigham in 2014. There's certain techniques that we've focused on, functional MRIs, we talked about EEG, but we've always been a mission-driven lab supporting these patients and their families, giving their families the most accurate information we possibly can to guide these life or death decisions. We've started doing some therapeutic trials to promote early recovery of consciousness in the ICU. That that mission, I would say, is what sustains me.
Yeah.
And I wish I could tell you that I'm running 3 miles a day and getting great sleep and all that, but uh, the that would not be the honest answer to your question.
Well, it's interesting, and it's not a judgment question. Obviously, it is an issue, and it's a theme where we look at the people who really are responsible for making critical care decisions. And I joke, my lifelong friend is a trauma surgeon, runs medical services for a couple hospitals or surgery in New Hampshire. But we joke about this, that in some ways, as much as I respect the profession, I would love to have their Whoop data displayed on their chest, right? So when there you go.
You
So
don't
when
want to
they
see it.
walk
It's not.
so when you walk in the room, I can say, "Oh, Dr. Edlow, I really respect your opinion, but you're running on 3 hours of sleep, and I know what that does to your decision-making abilities, regardless of mission." So it is interesting from a human performance perspective for me that part of this is, yes, let's continue to develop the science, let's continue to develop the therapies for the patients. We also need to continue to advocate for the kind of lifestyle for those who are serving these people that allow you to live your best life, have your best cognitive years, because you don't want to be sacrificing that in exchange for the gifts that you're offering your patients. I'll get off my soapbox. That's
Well
just
said. Well said. It's
so.
listening
So
to your
let's
podcast. I know I can do better, but back to you.
let's transition a little bit. So thank you for sharing all of that. But we met through this whole other part of your work. So we're now going to start wading into the waters of the brain of the soldier. Well, we'll use soldier as a larger term. So you have been the primary investigator in what is now going on its fourth year, or if I'm getting that right.
We built this partnership starting around 2020, so about 6 years. Our
Okay,
first
6 years.
study was 2021, but we started the partnership.
Okay, so we're going to start exploring this partnership between Mass Brigham General and some other partners. Homebase is involved in this. SOCOM is involved in this. So we're going to start talking about the ReBlast study. And as I understand it, and as we've been able to participate in my day job to some extent, the goal of this study comes back to this whole question of how do we identify the very early signs, ideally, of traumatic brain injury in all of its different nuances with active duty service people so that we can intervene in a variety of different ways to decrease their risk, decrease the likelihood, and in the event that they do suffer some form of TBI, which is very common in the field, that we have some way of helping them get to normalcy and excellence and maintaining that in their lives. Is that close?
Absolutely. It has been the honor of a lifetime to serve as the principal investigator of the ReBlast study, whose goal, as you mentioned, is to develop a diagnostic test that will detect the effects of repeated blast exposure on the brains of active duty service members and veterans. The motivation here is that those who serve our country, who protect and defend our freedoms, deserve the best possible medical care. And we have heard this story time and again of individuals who have been exposed to blast during the course of training or combat, who have developed symptoms at some point in their career, have sought care, and have received brain scans, and invariably those brain scans are normal. And without a definitive test to provide objective evidence for injury, individuals are often told that there's another explanation. Perhaps there's a psychiatric diagnosis, or
Mm,
maybe there's nothing going on. It's all in your head. Get back out there. And this is
Suck it
not
up.
in any
Yeah.
way, this is not in any way to say that the clinicians caring for these individuals are doing anything wrong. We just don't have the tools to see the invisible wounds of war, as they're often called. We lack the diagnostic tests that are needed to make the accurate diagnosis and to then provide the appropriate care.
Amazing. So let's unpack the term blast. Right? We say repeat blast exposure. I think people intuitively, when you hear the word blast, think explosion. And so obviously breaching, there was a point during, I believe it was, in the Middle East conflict, I think in Afghanistan, we had special forces operators who were breaching 10 doors a night. And I had an opportunity 2 years ago to witness a door breach. And I was at least 30 yards away, slightly behind a berm. And when they breached the door, we felt the back pressure. So I can't even imagine what it's like being that close to the door. But that's not the only definition of blast exposure, right? When we think about blast exposure and we think about pressure and counter pressure, it's through a broad range of exposure, operational exposure issues, isn't it?
Yes. And if I may, I promise I'll get to that in detail because it's a critically important point when we try to understand the exposure itself, the biomechanics, and how it might be affecting the brain. If you'll allow me to pause for a moment, I know we're on a podcast and not at an academic conference, but I do want to give a quick disclosure that we are grateful for support from the United States Department of War and Special Operations Command, as well as from the Navy SEAL Foundation Admiral Bill McCraven through the Bezos Courage and Civility Award and from the Gene Perkins Foundation. I do not speak for any of those entities. And with respect to financial disclosures, I do not have any financial relationships with a company or industry entity, and I do not endorse any particular product. So forgive me for inserting that. I know it's disrupting the flow of the conversation, but I
Totally fair. So
felt the
noted.
need to.
We're interviewing Dr. Edlow, independent thinker, who leads these efforts but does not reflect the thoughts of those sponsors and has no fiscal relationship to any of the parties involved. Noted.
Thank you. Back to your question, BLAST. So many layers to this. I'll start kind of big picture and then drill down to the detail. Many of us think about an improvised explosive device on the side of the road going off, military service members in Iraq, Afghanistan, wherever it might be, having immediate symptoms from this massive blast. Symptoms that are similar in many cases to the type of concussion that you described, falling off the monkey bars, or that an athlete might experience getting hit in the head. So immediate loss of consciousness, fogginess afterwards, loss of short-term memory, headaches, dizziness. There's a long list of symptoms that can go along with an acute event like that after exposure to a large blast. And we have our nomenclature is still evolving in the field, but most people would call that a blast traumatic brain injury. And if the duration of consciousness was short, we would call it a blast-related mild traumatic brain injury. Now, there's a goal in the field to move away from the term mild because a lot of people with a single event like that will have symptoms that
Last the rest
really
of their
affect
life.
their quality of life. So we are moving as a field, as a clinical community, away from the term mild, but that's historically what it's been called. That is not what our group is studying. We are interested in that, and there's some additional studies going on that I'm a part of that are focused on understanding that phenomenon better. But for that phenomenon, even though there are some limitations, even though our diagnostic tests are still somewhat imperfect, we know somebody's had an injury, their symptoms occurred immediately, there is a diagnostic code that a clinician at the VA or at home base or in any clinic can give to describe that event, to document that it happened, to ensure that that person gets the care that they need. By contradistinction, individuals who experience repeated low-level blasts, meaning none of those events are causing immediate symptoms, but cumulatively over the course of a career, thousands upon thousands of blast exposures can, in some people, and I'm going to choose my words carefully here because as a field, we have not proven cause and effect yet, but there are many reports, a growing number of reports, that there's an association between the number of blasts low-level blasts that one has experienced over the course of their career and the likelihood of developing symptoms later in life. Cognitive symptoms like memory dysfunction or inattention, psychological symptoms like depression or even PTSD has been shown to be potentially associated with this phenomenon.
Can we throw emotional dysregulation in there, right?
Absolutely. And as we start talking about the anatomic regions that are believed to be affected, they may explain the emotional and behavioral dysregulation, even aggression that some people experience. Physical symptoms like dizziness, imbalance, all of these symptoms have been described in individuals with a career long of blast exposure. And it can happen on a shorter term basis too. You talked about breaching. There are reports of people going to breaching training and having a concentrated period of exposure during which or right after which they might have some of these symptoms. If the exposures are brief, people tend to get better pretty quickly. But if over the course of a career, somebody is repeatedly exposed, and there's certain communities, certainly the Special Operations Forces community has their reports showing that they have substantial levels of exposure. There are military occupational specialties or MOSs in the conventional forces that have particularly high levels of exposure. So there may be particular communities within the military who are at highest risk. And again, I want to be very clear that the scientific community has not conclusively proven cause and effect, but the evidence continues to grow from a broad spectrum of studies, biomechanical, imaging, blood, and cognitive performance and self-reported behavioral measures that there's an association there between
Mhm.
the amount of blast that somebody's been exposed to and the likelihood of symptoms and changes within the brain.
So I'm gonna push my luck here. Um, we're still talking about using this term blast and sort of reblast. And a lot of that is pressure, right? There's a blast exposure. It's the pressure or the back pressure from it. What about just munitions? What about using larger armament? I was in a meeting where there was discussion of the gunners on Black Hawks, where you have, I get it's probably 50 millimeter machine guns. There's a tremendous amount of pressure and back pressure in that environment. What about the associated exposure of combat pilots under high Gs? What about SWICs I was down in San Diego heading to Coronado, and I finally saw some of these hovercraft, and I do not want to be on that boat. The amount of potentially concussive or preconcussive movement that they're exposed to. Does it eventually include all of these different types of exposure in theory? Or is the study currently very specifically looking at blast exposure as related to sort of conventional blast?
Several important issues that you raised there. First, to answer your question about the study, we are focused on repeated blast overpressure exposure, that we are laser focused on that exposure and what it does to the human brain and how it affects the brain health of the brave men and women who serve. Um, to talk for a moment about the different types of blasts, and then I'll comment on the other exposures you mentioned. Um, we, in the self-report questionnaires that we conduct with our study participants. Right now, our focus since the beginning has been studying active duty special operations forces personnel. And we will ask them to describe their exposure to blast overpressure all the way from the large explosions from IEDs and other large munitions, and often it's from enemy fire,
Mhm. Mhm.
to all the way down to what they experience from their own weapons
Mhm.
during training or during combat.
Sure.
And as you pointed out, there is blast overpressure associated with many of these different, pardon me, weapon systems. The magnitude of that exposure is less with smaller weapons, but it's still present. And there are many parallels here to contact football.
Mhm.
And what is the difference between a big hit that
Mhm.
knocks out
Mhm.
a player versus all of the repetitive subconcussive hits that happen every practice,
Boxing.
every game?
I immediately go to boxing, right? How many times do you get jabbed in the head, and then it's that really well, maneuvered hook that knocks you unconscious, but it doesn't mean that all those jabs don't have an effect.
Conceptually, there's a lot of similarity there as far as the same type of exposure happening in a variety of different degrees or magnitudes, but there's a critical distinction with respect to the mechanisms or
The
the
mechanics.
biomechanics.
Yeah,
Right.
understood.
And this will get
Yeah.
into your larger question about how do we think about um, riding on boats at high speeds or the G forces that are experienced by fighter pilots and planes. So, blast overpressure, the biomechanics are incredibly complicated. And I'll start with a disclosure that I'm not a physicist. I tried to read these papers as best I could in
Second
preparation for this
disclosure of the
podcast because
podcast for
I,
those
I
that
I
are
knew you'd
keeping
ask this
track.
question. And I will acknowledge that there are a lot of complexities and unanswered questions, but I'll give you my best attempt to synthesize the data. There is evidence, most of this is from animal models or from synthesis using either models of the human head that are built out of synthetic materials or that are modeled computationally. And what these studies show is that blast overpressure waves, the waves that are emitted from the explosion, either a large, IED, for example, or coming out of an M4 rifle, these overpressure waves can penetrate through the helmet and
Mm,
through the skull
mm,
and can reach the brain tissue via that mechanism. These blast overpressure waves can also penetrate through openings in the skull. For example, the eyes, the nose,
mhm,
the mouth, the base of the skull, the foramen magnum, and the ears. There are two different ways that these blast overpressure waves can reach the brain. There's also evidence that the blast waves can deform the skull transiently and cause pressure effects within the intracranial space through that deformation. So multiple things are happening all at once. As these overpressure waves reach areas of different tissue density. So
mhm,
for example, the outer layer of the brain, the gray matter, and the inner layer, the white matter, which have different densities. As the wave gets to that junction between the outer and inner layers, it can cause stretching or shearing that can injure the brain at that specific location. And there's several different places in the brain, for example, where blood vessels penetrate into the brain tissue, the
Hmm.
perivascular spaces,
Hmm.
have been shown to be susceptible to these types of forces. So anywhere there's a
And, and a
difference in
footnote
tissue density.
there, vis-a-vis the interview with Tommy Wood, we know that cardiovascular health for the brain, susceptibility or endangering cardiovascular health to the cardiovascular system of the brain, is the probably most likely pathway towards cognitive decline. So interesting. That's so interesting. I didn't think of it that way, but it makes so much sense that we like to think of things. I think intuitively we see the physical world. This also comes back to covert versus not covert consciousness. It's so much easier to think, oh, I feel this. It's pressure. It's moving my head, but it's the force that's driving the pressure. It's the wave itself that is really the danger. I was once in Santa Barbara during an earthquake, and I was in a building. We had just opened a new gym, and I was in a building, and we felt the quake. And then when the wave hit, we watched it move through the glass. And these were like 10-foot, 20-foot pieces of glass. And we just saw the glass sort of go liquid for a millisecond. We're similar conversation. We're talking about these incredible wave forces. And then once they get inside the brain, the idea that they can alter pressure because now can they resonate within the skull?
Exactly. There's several different mechanisms at play beyond the overpressure wave itself. One that's gotten a lot of attention that I'll mention briefly is called cavitation, the formation of air bubbles
Mm-hmm.
at these interfaces between tissue of different density.
Mm-hmm.
And this was a mechanism that I've had a hard time wrapping my mind around. So if others want to learn more about this, I would point you to a very helpful video that Dave Phillips, the New York Times reporter, included in one of his pieces where he smacks the top of a beer bottle that's filled with liquid with a mallet. And at the bottom of the liquid, at the bottom of the beer bottle, you see as the wave comes down to the bottom, there's a very brief moment of negative pressure at the interface between the liquid and the solid bottom of the bottle that leads bubbles to form. Those bubbles then rapidly collapse as more positive pressure follows, and the bottom of the bottle bursts, it cracks,
First.
and it bursts. Now, there's a very elegant article that recently published by Adam Willis, Tony Yuan, and colleagues at Uniformed Services University, highlighting some of the limitations of that model with the beer bottle. So it's not a
Mm-hmm.
perfect analogy,
Right.
but it's
Right.
at least helpful to kind of see these
Yeah.
bubbles form. And again, that process, cavitation, is believed to happen at the interface between tissue of different
Sure.
density.
Hmm.
So you think of all of these different forces being concentrated there, and it fits with the pathology literature that's come out of Dr. Dan Pearl's lab at Uniformed Services University, where Dr. Pearl, David Premer, and their team have shown that astroglial scarring appears to be concentrated at those interfaces between
Junctions.
tissue. Exactly.
Wow. Okay. So that's blast and blast pressure. So mechanistically, fundamentally different than the other examples I provided.
Exactly.
I could park it as that, mechanistically, fundamentally different. Not to say that there aren't risks associated with those other tasks, but because the mechanism is functionally different, the purpose of this study is to stay within a clear definition and to identify the resulting impact of overpressure.
Exactly. And
Okay.
two other, we could get lost in the biomechanics for a while,
Right.
so I'll keep this brief, but two other quick comments. One is that the acceleration G forces that you referred to on the boats going over waves at high speeds, or in a pilots in the fighter jets, the evidence suggests, and this is all very limited emerging evidence, but it suggests that that rapid rotation back and forth that's caused by G forces may be more similar to repetitive blunt head impacts that a middle linebacker might get in an
Mm,
NFL game
mm,
than to blast.
Hmm.
And the reason I say that is there was a paper, again, it came out of the lab at Uniformed Services University, Doctors Pearl and Premer, where they found chronic traumatic encephalopathy, this tauopathy, this process within the brain that's been associated with repetitive head impacts based on Dr. Amaki's group at BU, that there's extensive evidence for that in contact sport athletes. Dr. Pearl's group found that. Now, this is a single person, so take this with a grain of salt because it's an
Right.
N of one,
Right.
but an important observation in somebody who had been traveling on those boats in that community that you mentioned, who was found to have this process of chronic traumatic encephalopathy, which seems to be associated with repetitive head impacts and with those repetitive G-force acceleration, deceleration
Hmm.
exposure.
Incidents. Yeah.
Now, again, I want to be very clear that the evidence for all of this is limited to, a single case in with CTE and G forces, and the astroglial scarring evidence. Dr. Pearl's paper in 2016 in Lancet, that was 5 individuals. So, small sample sizes.
Most of
Nevertheless,
this, I'm going to jump in. Correct me if I'm wrong, as is always the case, but most of this is still relatively small sample sizes, right?
exactly,
I mean, just by the nature of how the work, it's not like a clinical trial where you enroll hundreds or thousands of people and you monitor them remotely. This work is very labor intensive and it is very small scale, high quality small scale.
exactly. And that the last point I wanted to make about exposure is many individuals in this community, particularly the Special Operations Forces community, are exposed to not only repetitive blasts, but also blunt head impacts. Let's say a hard
Right.
land and
Right.
a jump, or the acceleration deceleration G forces that you mentioned. They might be exposed to that in other contexts. Hypoxia during a jump or during diving. There's a whole, or burn pit inhalation. So when we talk about why, after all of the billions of dollars that have been invested in this field, we don't have definitive cause and effect evidence, this is an incredibly complex, multidimensional problem where even when you try to account for all of those other exposures, it is very difficult to do so, either because we don't have large enough samples or because we can't adequately measure the other exposures.
Sure. Sure. Or how do you track the cumulative effect of these exposures when you are only measuring that operator episodically? I mean, it makes me think that you would literally need like a cognitive version of a glucose monitor or constant glucose monitor in order to be able to get to that kind of causation, because otherwise you're trying to recreate this tapestry of history, and we already know that despite everything we know about the brain, it still surprises us. Yeah.
Beautifully said.
Interesting. So what have you learned? Let's jump here. What have you learned so far, and what do you hypothesize at this point on this
So
plan?
I'll share with you the kind of brief arc of our journey. We are grateful to Vice Admiral Tim Szymanski, who was the deputy commander at the time, an incredible champion of brain health, who launched the study. And with his support, we performed the ReBlast pilot study from 2021 to 2023. This involved 30 active duty operators from all branches. Their mean age was 37. Their average duration of service was 17 years. So these were 30 individuals who had served for 2 decades in the global war on terror. They had extraordinarily high levels of blast exposure, orders of magnitude beyond what had previously been reported in conventional forces. And the key finding from that initial pilot study was that the more blast exposure an individual had over the course of their career, the more likely they were to have changes in their brain in a specific location of the frontal lobe called the rostral anterior cingulate cortex, the RACC for short. And that observation with respect to this particular region was found in structural imaging with MRI, in functional imaging, resting state functional MRI, and with positron emission tomography, PET. So 3 lines of evidence that all converged at this single region of the brain
Interesting.
being affected the more blast exposure somebody had. Now, this was a pilot study, small sample size, so I want to emphasize that these results should be treated with caution and
Hmm.
humility. but it
Mhm.
provided a basis for launching the next phase of our work, the ReBlast Precision study, which we just launched a few months ago.
Mhm. And what do you hope and ReBlast Precision is gonna be 4 years, right?
Exactly.
So let's get in a time machine. We're gonna call it Brian's optimistic time machine. It's 4 years from now, and you're wrapping up the study. What do you hope to be able to share?
To answer that question, I'm going to take a step back and just give you a sense of how we designed the study and what we hope to accomplish. So, first, I want to mention that when we designed the ReBlast Precision study, again, it just was launched a few months ago. This was based on the foundational results from our pilot study, as well as results from other groups. Dr. Jim Stone, for example, at University of Virginia, and there's several groups around the country and around the world who have been studying this issue. And so
Mhm.
we designed the next phase based on all these emerging results. And the goal is to, based on the lessons learned, focus the types of imaging tests that we're performing. So in the first study, we did 4 different types of brain scans. Now we're doing 2 different types of brain scans. We are focusing on certain blood-based biomarkers that have shown a lot of promise from our prior work and other groups like James Stone's.
Mhm.
And we are trying to develop an initial diagnostic testing protocol for repeated blast brain injury. I say initial because it is going to take many more years of work to optimize and to perfect this, but we as a field are getting close. We're not there yet, but we are getting close. I truly believe that, to being able to see the invisible wounds of war, the effects of repeated blast exposure with imaging tests. We're getting very close to being able to characterize those effects on the brain with blood-based biomarkers. And then something that you and I have talked a lot about is, how do we characterize the effects on cognitive performance, psychological health,
Right.
physical performance?
Right.
And one of the big challenges there, as you know well, is that blast exposure, blunt head impacts, acceleration G forces, all of these things can affect cognitive performance, psychological. So, it remains to be determined if there's a constellation of symptoms that is specific for the effects of blast exposure. That hasn't really been determined yet. It
Mhm.
may be that the Venn diagrams of symptoms overlap so much that you can't really tell based on symptoms alone
Mm.
whether somebody's injury is related to blast or blunt head impact or G forces, which is why the imaging and the blood tests are so critical, because we might get that specificity from those types of assessments.
Okay. So then taking you to the 4 years, the end of the 4 years, the win would be, for lack of a better term, more acute or stronger indications that these different tools are able to identify, I assume, early onset of this type of exposure, right? I mean, I assume the goal, if we dream, break free of the limitations of science and funding and studies and IRB, the dream is to be able to come up with a diagnostic or a series of diagnostics that allow us to identify and flag the very, very early onset of the impacts of blast exposure with the goal of some sort of remediation.
Exactly. So, starting with the principle that detection is the foundation upon which prevention and treatment will be built.
Okay, there we go.
We cannot optimally prevent or treat what we can't see.
Perfect.
So, if you ask me, what would I hope to accomplish over the course of a career, or what do we want to accomplish as a field? We want to be able to help people get better who are experiencing symptoms, and we want to be able to prevent this from ever happening in the first place. But in my opinion, you can't achieve those goals until you can detect, track, and monitor what you're
Right.
looking for.
Right.
So,
Detect, track, and monitor. And so that implies that as wonderful as fMRI is, it just doesn't scale across the force. Right.
and one of the reasons that we and other groups are so excited about blood tests, cheaper, more readily accessible, particularly in austere combat environments. But just to kind of paint the picture of the landscape of what we all hope the future would look like if we and other groups are successful in developing a diagnostic testing protocol. You could imagine that the many teams that are already actively engaged in reducing exposure, mitigating exposure, and I want to highlight, there are many, as you know well, many members of the military at all levels of leadership who are already implementing prevention and mitigation strategies, even if we don't know exactly how to detect and measure this
Yeah.
injury.
Yeah.
That hasn't slowed military leaders down from trying to prevent it and
Right.
mitigate it.
Right.
But what I'm suggesting is that we can't optimize and those efforts and make them most effective until we can
No,
truly measure.
until we measure it
What,
and truly understand. Mitigation without causation is going to be much more art and much less skill.
exactly.
I mean, an
So
example of that I heard in a meeting was, I'm going to come back to the Black Hawk example, and I think I'm getting this right. So I'm saying this, my disclaimer, illustratively, right, not accurately, but there was they were looking at a helmet and a face shield that the thought was it would block some of the overblast pressure. And unfortunately, additional research discovered it actually trapped the overblast pressure inside the visor and created this echo chamber that made it worse. So the operators could actually feel it and were just ripping the helmets off. So the better we understand the mechanism, the better we can detect early, the better we can track, to your point, the more effective mitigation can be, because now we know what we're mitigating against.
exactly. Um, let's talk now about treatment. So there are a couple of considerations here. One is we talked earlier about astroglial scarring, scarring related to the astrocytes cells that support the neurons within the brain, scarring that occurs at the junction of the different tissues. That's been seen under the microscope, and that's believed to be the end stage of a substantial amount of cumulative blast exposure. Prior to scar formation, though, there is almost certainly inflammation. Activation of those astrocytes, other inflammatory cells in the brain called microglia. And so when that inflammatory stage is occurring, can we treat it? Can we decrease the amount of deleterious inflammation? There's some types of inflammation that are bad for the brain that may lead to scar formation. Can we enhance the type of inflammation that is healing and
Right.
advantageous?
Right.
There's a very delicate balance between inflammatory cells and markers that are trying to heal the brain and those that
Hmm.
are leading to that scar formation.
Hmm.
There's still fundamental gaps in knowledge about how to figure out how to target or enhance one form of
Hmm.
inflammation as opposed to the other.
Hmm.
But once we can identify the inflammation that precedes scarring, that creates an incredible window of opportunity
Opportunity for intervention. Yeah,
for treatment
that's interesting.
prevention.
Yeah.
Um, in those who have, even if somebody has scarring, there may be many ways that they can recover. There may be ways that their symptoms can improve. I want to highlight this point that, if someday our diagnostic test is good enough that it can identify the scar, that is not a death sentence. There is still the opportunity for healing and plasticity. So many members of this community, you've heard the stories of people having difficulties, and I don't want to minimize the seriousness of those difficulties, but overcoming them over time and
Absolutely.
finding ways to, have
Absolutely. A
a
variety of
meaningful
different
quality of life.
treatments are absolutely proving a high level of efficacy.
But knowing how to treat somebody. Does somebody need therapy for PTSD, for a blunt head impact TBI, or do they need treatment for repeated blast brain injury? Those are different treatment pathways. And if you look at centers of excellence, NICO, home-based prep, I mean, they do an outstanding job of providing the best possible care based on the diagnosis they think that individual has.
Hmm.
But until we can definitively see the effects of blast within the brain,
Hmm.
you can't make a fully informed judgment about what path that individual should be on. So it will guide treatment pathways as well. One final thought, and this speaks to the members of the military community, both active duty and veterans, who have died by suicide.
Hmm.
Almost every Gold Star family who I have had the honor to meet has said that they believe their loved one would be alive today if they were given a diagnosis saying there is an injury within your brain. The validation, the vindication of knowing that this isn't in my head, it's not some underlying psychiatric issue, something happened to me and it explains the symptoms that I'm experiencing. Every Gold Star family I've spoken to has said they believe that just knowing that information would have had life or death implications for their loved one.
Mm.
And so, even beyond prevention or treatment, one of the motivations that I and our team have is just giving people the knowledge of knowing what has happened to them. There is inherent value in that.
It's an empowerment question, isn't it? It potentially moves you from disempowerment to empowerment. Even though you may not know what to do about the injury, you at least know this isn't just quote unquote in my head. And it's that complete lack of control and lack of power that takes many of us down very dark roads. You know, it's part of the depression cycle. Yeah.
Uh, Absolutely. And I've never served. I'm not a veteran, and I'm I'm a clinician and a scientist. And my interactions with the military community have been in the context of these research studies, and then getting to know um, some members of the teams and leadership along the way. And we talked earlier about what kind of sustains us, and I talked about mission. And for the early part of my career, really, what my inspiration and mission was helping people recover consciousness after a severe brain injury, trying to support their families. But with this new work that we're doing on Blast, it has been a profoundly inspiring experience to meet individuals who are selfless, who put themselves in harm's way and do truly mind-blowing things that are hard to really even wrap your mind around, both physically and cognitively.
I'm with you.
It,
The longer you're an outsider having the opportunity to talk to these people, the more in awe you really have to become. Yeah.
and I think I realize your podcast is about cognitive performance, and we haven't talked that much about that. So I'll just
It's okay.
briefly comment that I think many of us, myself included, in the civilian world, we think of like special operations forces as, can do physical things that are unimaginable. What I did not understand or appreciate until meeting members of this community is that they are just as elite with respect to cognitive performance,
Without a
and
doubt.
that the demands of the job are just as great with respect to cognitive function, psychological resilience as they are for physical function. And, meeting people who perform at the highest level, sacrifice the most, put themselves at risk, they deserve the best medical care, full stop. And, it is nobody's fault. It's just, we're not there yet. So much more work needs to be done. And so our team is committed to this mission. We're honored to have the opportunity to partner with this community. And, the first goal is the diagnostic test, and then lots more work to do after that.
I appreciate everything you just shared, and I agree. I I'm curious, put you on the spot here. You listen to the interview with Dr. Wood. Dr. Wood talks about headroom. He's his book's coming out, I think, this month. The Stimulated Mind. I've had a chance to pre-read it, and it's great. It's dense with information, but this idea that we've understood physically, and I think again in the forces they understand this. You don't train physically for the mission. You train for beyond the mission. You want to have physical capacity that exceeds what the demand will be, because you never want to be at a demand deficit when life and death are on the line. Do you instinctively, so you might take your scientist hat off for a moment, because I'm looking for more your opinion. This is in fact based, but intuitively, instinctively, do you think that there is value in doing everything we can with these armed forces, special operators, technicians, to increase their headroom? Does that put them in a better position? Because it's mechanistically different than cognitive decline. The idea that if we can increase your headroom, we're all going to have some cognitive decline that comes with age. But if we can get if we can get our cognitive levels as high as possible, we have more space. Do we think that may be true here as well?
Short answer, yes, but it's such a complex issue, as you know well. So, we've talked about cognitive performance optimization from a variety of different perspectives, virtual reality devices that allow you to immerse yourself in a world where you are forced to perform complex decision making, rapid reaction time in a way that is really hard to simulate on a laptop or an
I
iPad.
know a system. I'm familiar with one.
and appreciate your leadership in that domain. Um, that I'm certainly not an expert in that, but I think intuitively it seems that there would be a role for that type of training. But as you know well, I'm sharing only what I've heard from members of the community. People will say they don't wish their training was any different. And that, that's another remarkably inspiring thing about this community is that I have not heard a single person say that they have any regrets. They knew what they were getting into. They volunteered to serve at the highest level. They're incredibly proud of that service. They recognized that there were risks, and once, if somebody develops symptoms, of course that's concerning and it affects their lives. And people you know, want to focus on how they can improve the quality of life for their family and for whatever
Mhm,
job might come next after retirement to
mhm,
veteran status. But, I have not heard any regrets. In fact, I've heard a lot of, you've got to train under the most real circumstances with that breaching charge, with the real, overpressure coming out of your own rifle, because you've got to know exactly how it feels during training so that when that moment comes to perform a high stakes mission, you're going to perform at peak level. And so I don't know if this addresses your question, but this is the way I interpreted it is thinking like, can you achieve cognitive performance optimization through simulation, through other means that reduce exposure?
yeah,
Maybe,
that's the
but
critical question. Yeah, I think, it's not one or the other, which I think is where sometimes people get confused, and we don't need to travel down the whole VR intervention road. I think in both sport and in service, there's only so much physical training that you can do and so many reps at that incredibly high level of stress that simulates or reflects the mission before you start to have negative and adverse effects against the operator. And you want the operator to go into the fight in peak condition, not in a fatigued state. So my opinion is there is an opportunity here to complement that work, not replace it. I don't think you can create a simulation that's ever going to replace the intensity and the physical changes as environment and pressure and everything else. But I do believe we can get deep, powerful cognitive reps. Can you make decisions under tremendous pressure? Can we push your brain to really invoke neuroplasticity at very high levels so that you don't have to have as much wear and tear all the time? And you have potentially if we can get 1% more cognitive capacity on the table, that is probably going to make the difference between mission success and mission failure. That's just my
well,
opinion.
well said. And I'll use that as a transition point to talk about readiness, something that comes up a lot. How can studies like ours empower the individual operators and team leaders and commanders to truly understand in a quantifiable manner the readiness of their team. And one of the biggest limitations in this field to date has been a ceiling effect on cognitive tests because you have such high performers.
Mm,
Subtle changes associated with the exposures that we've been talking about might not be detected
interesting.
by current tests, whether it's paper and pencil, laptop, iPad based. And so the need, and this is something that we embraced in the ReBlast precision study that we just started embarking upon, the need to push people to their limits and beyond
Hmm.
so that there is not this ceiling effect, so that no human brain can possibly ace this test,
Right.
allowing us to detect those subtle changes, even in the most elite performers. That is how we are truly going to learn how blasts and other exposures affect the brain, and then
Hmm.
which prevention and treatment strategies are most effective. So, there's so many different domains of this research effort where we need to optimize our methods, whether it's
Hmm.
imaging, blood-based biomarkers, cognitive performance, and that's what we're hoping to do in this new
Yeah.
study.
That was well said. I think, to reflect that back, you're never on a paper and pencil test, you're never going to press these operators to their absolute cognitive capacity. It's mechanistically limited. And potentially environments like VR and XR give us the opportunity to do that. When we first, I tell this story from time to time, several years ago, actually during COVID, I had this opportunity to go out to Fallon, Nevada and meet with the incoming Top Gun class. And it was kind of a highlight of my career as the CEO of Neurotrainer in terms of cool things I get to do, because a lot of it is not. And they invited me to come out and do a brief. And I had no idea until I was already committed that this was a very big deal. 30-minute brief, you have to be on the dot, you can't screw it up, etc. But as we go out there and we're going to do some data collection with the incoming class, I had this existential moment of terror where I thought, well, what if our test doesn't work? What if they test really poorly? And then we have to either say, you picked the wrong people, or our test doesn't work. And fortunately, it went the other way. And we saw some of the best data we'd ever seen diagnostically from this group of pilots. And we continue to see that. It was we at Neurotrainer have an opportunity to work with some of these elite forces. You're right. It's not just physical. Cognitively, they are literally redefining the charts. They're not off the charts. They're redefining the charts. So I think it continues to be a promising field, and we're happy to support all of these efforts in any way we can as well. Well, Brian, we traveled a lot of ground as I knew we would. I was fascinated. I've known you for a while, and I learned so much over this last hour and 20 minutes. As we head into the final stages of the interview, any final reflections? And this is open-ended. It doesn't have to be as a researcher. It can be as a thinker, as a parent, as a husband. If you step back from the perspective of the brain and consciousness, what are your takeaways of your journey so far?
It's a big question. I'll reflect for a moment. I'll point to a really compelling message that your prior guest, Bain, shared about the why. Why do we do any of this? You asked me, how do I keep things together? Am I exercising, diet, sleep, all that? The motivation, the inspiration, the why has been serving specific communities. And, right now, where I'm focused, where our lab is focused, our team at Mass General Brigham is serving military service members and veterans who protect and defend our country. It is a community that is easy to be inspired by. It is the kind of the organizing principle of my professional life is to just find some way to help. Right now, that's manifested in these studies to develop a diagnostic test. If and when we and other groups are successful, we'll take it to the next step, working on prevention or treatment. But I think what is, there are a lot of challenges to being a physician. There are a lot of challenges to being a researcher. Funding, it's no secret that funding is tighter than it's ever been. But, having that why, that North Star that guides you has been kind of the organizing principle of my journey. And, I think about the first study that we did, the 30 individuals that we met. For our team, the most fun, interesting, and inspiring part of that experience was just having lunch. Just sitting down and talking and hearing their stories. And those individuals opened up to us, told us what inspired them to pursue a career in Special Operations Forces, what it was like, what their family lives were. It was just incredible to learn about the experiences of these 30 individuals who have done as much as anyone on the planet to protect and defend our country. And it's, meeting people like that and hearing their stories, it gives me and our team an inspiration to move forward.
Wonderful. Well, we appreciate all the work that you and your team do, and we're delighted to be in partnership in whatever way we can. So it goes both ways. One of the reasons I love to do this podcast is that's my experience, is I bring guests on and I typically walk away awed by my guests, and this was no exception. So took a long time to get you on the show, but I'm so glad we did. And thank you for sharing all that information. If somebody wants to contact you, this is a pretty standard question that'll surface. What's the best way to do that, and if it's appropriate?
Absolutely. First, thank you for the opportunity to be on the show, Noah. It's been a great discussion and have learned equally, if not more, from you. And just looking forward to continuing this collaboration. Best contact information for me is my email address, B as in Brian, and then my last name, Edlow. So it's BEDLOW at mgb.org.
And I'll drop that in the show notes. And wonderful. Super fun. Thank you so much for making the time. I know you're a busy man, and I look forward to seeing you face to face next time I'm in Boston. Last time I was there, you took me on a tour, and I got to see the state-of-the-art fMRI machines that I never want to have to get into because they're really claustrophobic, and I have a little bit of claustrophobia. I look forward to breaking bread, and I look forward to continuing on this journey together. Thanks again for joining us.
Thank you, Noah.